I'll show you. Great. So thank you for joining for the second week of the bootcamp. Last week we discussed kind of the overview of TriNetX. There's a lot of, I know, kind of non-platform based information, but this week I think we're going to get more into some of the kind of core concepts that will enable you to make the best use of this really powerful research tool. We're going to be focused on defining and exploring cohorts, because cohorts are really the central way that you can both develop your study. I mean, they're foundational to how TriNetX thinks, but also they are essential to ensuring the validity and the quality of your data analysis. So understanding the cohort explorer and the cohort development and the query development components of TriNetX that we're going to look at today is going to be really, really important for all of the rest of the work you're going to do in the future. And the better you understand it, the more effective you're going to be out of the gate, and the more useful you're going to find this platform as we go. There's a lot of like ins and outs and nooks and crannies in this part of the platform as well. So making sure that you understand this really clearly will definitely enable you to get started on a really strong foot. Oh, great. We got a couple more people joining us. Thank you to everybody for joining. I was just saying that we're getting started with the Cohort Explorer today, and looking more at defining and exploring cohorts in TriNetX, as I was just saying one moment ago. This is really central to using this platform effectively and really getting the most out of it. So yeah, let's get started, and we'll take a look as we go. So again, I'm Daniel Novak. I'm here. I'm the Director of Student Scholarly Activities at the School of Medicine. My job is to support medical students and faculty in helping medical students to engage in research and to connect students with research opportunities. And I think TriNetX has been a really great way. We spent a year negotiating the contract to make sure we could bring the platform to UCR. And that has been really productive. I think it's paying off dividends. We have students getting publications in really high quality journals. But more than that, more than all the CV items and all that kind of stuff, we're really seeing our students understand the research process by doing it, as opposed to just listening to someone tell them about it or being along for the ride for someone else's NIH-funded grant that they really don't know the inner workings of. But by starting a small project, even something that's just an informatics-based project like this, they really get a sense for how these projects, how a project gets constructed, how you construct a question, how you analyze data and develop that stuff. So that's been really, really great for us. This is our kind of overview for the next couple of weeks. This is week 2 of 6. Week 1, as I said, was navigating the TriNetX concept and interface more broadly, and getting kind of a project rolling, what buttons to click to do that. If you need any help with that, you can refer back to the recording. Really quickly, our recordings are all located on the Scholarly Activities portal. I will show you right here and put the link in the chat that they are available through our Scholarly Activities portal here, and the link is in the chat right now. So if you'd like to go back and review that, this is a great time to do that and stay up to date on all of the new stuff we're developing. I also want to put the link back in the chat for, we haven't yet released this fully, but these are some of the TriNetX publication tools. We'll be covering this later on, but for those of you who have already started developing stuff in TriNetX, these tools are very, very useful for that kind of stuff. For helping to kind of bridge the gap between your TriNetX project and a publication or a poster. We're also based completely on student suggestions. We're developing some additional graphics tools like a bar chart maker for those who are not maybe as adept with Excel, and also a power and sample size adequacy checker that we'll be releasing probably pretty soon to help you assess your TriNetX sample statistically for making sure that it's you have enough people to justify the kinds of relative risk numbers that you're coming up with. Again, you're going to learn to navigate the TriNetX interface through our bootcamp. You're going to compare outcomes between patient cohorts, use the propensity score matching to reduce confounders. And this year, we're also adding some additional ideas on AI and how you're going to be able to use that as well. You're going to learn today to use advanced cohort definition features, adjust temporal issues in your study, and make sure that you're accounting for the role of time and order in the things that you're looking for. It's really easy to do that poorly in a TriNetX study if you don't understand what you're looking at. We are going to then look at examining your cohorts for confounding factors and inclusion-exclusion criteria, those that you may know about to start with, but those that you might have to explore using the Cohort Explorer, which is appropriately named. And we're going to help you develop your cohort construction diagram, which we have a template for on our website, and I will show you all of that information pronto. So yeah, today, advanced cohort definition and exploring cohorts, which are part of our overall process of developing our foundation in our house, which is my clunky metaphor that we talked about last time, or the rapid development process we're right about here in that blue square, building your cohorts. If you're doing the even more rapid prototype or the more rapid research process that I defined last time, we're somewhere in the red right here, pulling out the key features of a study and reconstructing the study in TriNetX. You'll need all the skills we're going to talk about today in order to do that and to restructure that structure on your topic and cohort of interest. And again, we're working right now on our foundation so that when you build your house, your study on top of that foundation, you have your confounders identified, your time and order events, and your inclusion and exclusion criteria crystal clear to help you answer your important research question. As I said last time, also, the library has a copy of this book. I recommend it. I don't think it was terribly expensive on Amazon. It's a couple of years old, but some of the stuff never goes out of date. And I think it is really, really does a great job of concisely describing a lot of the topics in clinical research that are relevant in terms of the methodologies that we're going to discuss today. And again, as we go, I'm going to be working through this example study based on this internet clown who made the claim in his study and in his Instagram that Alzheimer's is a physician-created disease and that it didn't even exist 40 years ago, and the increased rates are as a result of doctors' overprescription of statins. That is a huge claim to make. That is not an extraordinary claim like that requires extraordinary evidence. So I think that's something that using TriNetX to investigate was worthwhile and winds up actually being really interesting to look at to help build it. Based on that, there is the kind of between where we were last time and where we are now, I would imagine you would do a literature review to identify what is currently known about your questions. And I found that, of course, there is an extensive literature on statins and Alzheimer's disease out there. But there are actually remarkably few solid answers and a lot of gaps related to confounding factors, comorbidities, etiological theories. For example, even just issues related to methodology. Randomized controlled trials are fantastic, but for assessing the impact of a disease, but following people for long periods of time and making sure you're following the right people to identify whether they're at higher risk of developing Alzheimer's disease is actually remarkably difficult to do in any randomized control trial, and there are pretty glaring deficiencies in the existing research in Alzheimer's disease, which is not to say that the studies weren't done excellently when they were done, but as a whole, zooming out to look at the total corpus of evidence, there's a lot of potential questions still on that front. So now we have our questions. We can start defining our cohorts. Accurately defining your cohorts is essential to getting that reliable picture of the right people that I talked about a moment ago. And the validity and generalizability of your study comes from how well you can do that cohort definition. I really want to talk quickly about methodologies in TriNetX. As I said last time, there's always going to be a kind of theory component and then what buttons to click to use the platform component as well. Please don't skip the theory part because it really, without understanding what you're doing, you may wind up producing poor quality work. But basically, TriNetX studies, most of what you're going to work on takes 3 or 4 forms. First, cross-sectional studies cohort studies, and case control studies. And these are fairly well understood research designs. And we're going to go over them in just a sec really briefly. But I also want to introduce two key terms that we're going to revisit again and again throughout this course. The first is the concept of a cohort. So a cohort is just really simply a group of individuals who share a common characteristic, whether it's an exposure, a diagnosis, or a procedure, or a medication, any number of different things, can define a cohort. Age is a very common one, but having red hair, for example, could also be a cohort definition. Really anything that you're using to do that, dividing the bounding of your group is what defines your cohort. They start with a selected specific starting point, which is an index event, which I'll talk about in just a second. And they're followed through time to observe those outcomes that they face. Or we can go backwards in time to see what they have in common that might lead to those outcomes. We're going to talk about temporality in just a moment. Also, we can compare differences between these two cohorts and exposed and unexposed groups to see what happens to them, whether the thing that makes them similar or different in the between cohorts, how that impacts their outcomes long term. But I also want to talk about a concept called index event. Some more epidemiologically minded folks on the video may be aware or know about this concept, but the idea is that it's a specific point in time that marks the start of a follow-up or the start of the study for a cohort. And basically, the simplest way to think of it is the first day that all the features of the cohort become true, that all of those features are present in that person's, in this case, electronic health record. And we're going to look at what the impacts of that would mean. And it's often based like the first day of a diagnosis or the first day that they had a diagnosis and then were given a specific medication. Perhaps this is important to think about. They might have had that medication, that diagnosis for years, for example, type 2 diabetes. But if your study starts on the first day that they had that type 2 diabetes and got semaglutide, well, that's your index event. That's the first day that both of those things are true, even if they'd already had the diagnosis for many years. But these index events are used to anchor the timeline for measuring before and after effects or long-term outcomes. And they're really critical for defining those exposure windows and outcome periods and really matching the logic between these studies. So we're looking at apples and oranges and not just a bunch of random people who had unclearly related events occur to them. Really quickly, if you want to think about what I mentioned a moment ago in terms of case control studies, and cohort studies and cross-sectional studies. A cross-sectional study occurs at one point in time. And we can do this with TriNetX and just look at what happened in the year 2025 to all the people who had type 2 diabetes and were on semaglutide. What occurred, right, to those people? Did they develop, did their A1C, what level was it at that time? Case control studies, on the other hand, look at the past. For those who were born after the year 2000, this is a visual joke that I hope some of your elders will get as well. But going back into the past is one of the real strengths of case control studies, which comes with the problems related to confounding or to not being able to control causality or understand the relationship of cause and effect. We give that up when we look to the past, what these cohorts were like in the past that causes an outcome in the future. We can't control for some of those things. This heading is incorrect here, but this down here should say Back to the Future is our cohort studies. We're looking and following a group of people from that index event and in time and moving forward into the future to look at what occurs later on. And that's really important to understand how are we following people in time. That really impacts how your cohorts are designed and how you use TriNetX. Really quickly, cross-sectional studies observe a population at a single point to assess the prevalence of a condition, exposure, or characteristics, as I said a moment ago. In 2015, after the passage of the years after the passage of the Affordable Care Act, or rates of chronic illness decline, or in African-American populations, there's a typo in here. It's kind of a static cross-section of that occurrence in that time frame. As I said, case controls, we're looking backwards. Very similar group. How do they proceed forwards in time from that point in the past? And how does their common or different component impact those outcomes long-term. So older adults with hip fractures to similar individuals without hip fractures who are control, and examine prior use of semaglutide to see if there's an association. I have multiple students who are interested in ortho who are working on variants of this kind of approach. And it can be done pretty well here. Again, there's a lot of possibility for different kinds of bias that creeps in here, but it is a fairly standard epidemiological approach to studying the origins and the impact of cohort membership. Another flavor of this that you might see is a nested case control study. I'm a little more of a fan of this because it's a little more apples to apples when you're making your comparisons, but it's comparing subgroups. So of all the people with a particular kind of cancer, if one gets a medication and the other doesn't, what are their outcomes? We're not comparing those folks with cancer to all people who ever lived, right? That's too much. It's too much variance in that gigantic pool of people. By nesting that case control study within a smaller pool of people, we're looking more clearly, we're controlling for more of the potential kinds of variance that we might see out there. Cohort studies, again, looking forwards. That's some folks coming in. Looking forwards, they follow one or more groups over time to compare the incidence of that outcome for those exposed to that factor versus those not exposed. That's pretty straightforward, but we're following them from the index event forward as opposed to looking at the cohort and looking back at common characteristics that maybe they exhibited earlier. So do patients over 65 who receive statins have lower rates of Alzheimer's disease over that 5-year period compared to similar patients who did not receive statins? We're looking forward into their work. And you can do another flavor of this, which is a before and after study. So comparing outcomes before and after an event in the same population. So before they received the medications and afterwards, and you can see whether there's an impact in how things work out with them. So that's the kind of theoretical component for today. There's a lot more to say on them, but that was kind of the big picture, thinking about time and its relationship to the events that we're interested in, case control and how that relates to looking back into their past and seeing what comes in the future versus starting with a group and then seeing where they go. Those can be very different, lead you to different outcomes. And again, there's a lot more, there are acres of books on those very design approaches, and they're really important to follow. So last time, though, we discussed the query builder, and I just wanted to revisit this as we move into our TriNetX content for today. The query builder, I just want to call out some important features. This is the main screen you're going to see when you enter into your TriNetX study. You're going to notice right there in the top left of this central area of the screen, your networks, the networks you have access to. That includes, for pretty much everybody here, the global network, the UC network, and the US network, where the US is usually the most commonly used one we have. This was the term search box that helps you to find related terms in the ICD-10, CPT, LOINC, all the different approaches, the RX norm, different code structures that are used to quantify in electronic health records or to signal the implementation or the particular appearance of something in a person's health record. This is our cohort definition space down here. Now that refers to the entire box area here that you might see. And those cohort definitions include all of the terms that you find in there, as well as additional kinds of logic that you can use to define your cohorts. I want to call your attention to that blue button up at the top, the Count Patients button. That helps you to actually run your query to find the individuals who match your parameters. And over here, you're going to see your query cards. As you do more and more queries out there and you develop them, they'll start to stay. Every time you hit the Count Patients button, you'll get one of them over here. And I recommend keeping them named and really nicely organized, or you're just really going to lose track of everything quickly. Let me just quickly mention, as I said, each of these cards represents that time you hit the query, but it does also contain important and useful information for you over here, including the number of patients who ran the query, the date and time, what the number of healthcare organizations was on the network on that date, and what network was running. So that can be really important later on because, number one, journals expect you to include that information in any of your write-ups. And number two, So you can see, if there are any changes to those over time, you can assess whether there have been any changes to it. And we'll talk a little bit later about TriNetX as a dynamic network, meaning on any given day. I think when I took this screenshot, there were 64 on the net, 64 schools or healthcare organizations on the network. That was probably about exactly a year ago this week. And now there are 72, I think. So they've added 8 more groups to the US network since then. And that translates to roughly 27 million patients or so, 17 million patients or so. So you can see that this changes a lot over time. And being able to make sure when you ran your queries and everything like that can be very important. Right, so we're going to talk about term groups next. Term groups are really important. They help us to specify additional relationships within our cohorts by grouping our identifiers for our cohorts in useful ways. And you can connect your terms by the number of instances of a specific event, like how many times did they have a particular surgery, how many concussions did they have. You can group your terms, and I'll show you how to do all this in just a second, by the number of unique instances of that. So, for example, you might have a list of risk factors that people have, and you want to see and make sure that when the study starts, people have 5 of 10 risk factors. For example, pain, a particular kind of pain, or a depression, anxiety, and suicidality. If those are 3 of your 4 factors right there, it'll find those folks who have those factors already in their record during the time frame you specify. The related group function is probably the most important and one that I really think everybody needs to learn well so that they can understand how to orient relationships in the system in time. And you can also specify within a time constraint. This was very valuable for a group of students who looked at rates of abortion and abortion care services, both medical and medication driven and also surgical post Dobbs. And they were able, they really needed to be able to identify a time constraint in there to make that study work properly. We'll talk a little bit about that, about time shifting when we get there, because depending on what way you're using time constraints, it may or may not work for your study. So let me show you, when you are in TriNetX, in the bottom of your kind of main query area, and I'll show you this in context in just a second, you'll find a create a new group button that you can use to start grouping your terms as you add them in. In this case, these are all the statins that I wanted to include in this study, right? All the common ones, plus a couple of older ones that are not as used. And you can use Boolean logic and an or, just the way we can with individual terms, to combine these groups of terms to catch the right people. You can think of these groups as circles in a Venn diagram. So what you want to do with your circles is make sure that they start getting more and more defined concentric areas in the middle to make sure you're really getting exactly who you want. So people who had this but never had Alzheimer's, right? So we want a circle that's non-overlapping with the Alzheimer's disease group, for example. So let's take a look at that in context really quickly. You can see that, when I scroll down, this is my control group, my non-statins group for my study that I was describing earlier. You can see that I'm defining this. You do need in TriNetX to make sure that any study you're doing has some sort of positive component to it. You can't just define all people who do not have the following characteristics. You need something that enters people into your study. So in this case, for my control group, because they are defined by not having statins, I need to have some sort of positive feature for them. And in this case, I used ever having been, for any reason, prescribed an ibuprofen or a vitamin D. And the reason is, generally, most people aren't prescribed ibuprofen for extended periods because it can be physiologically quite bad. And also because vitamin D, as near as I can discern from the research, does not have a direct cause-effect relationship with our subject of interest, which is Alzheimer's here. So it's probably related in other broader ways, in that it's part of good health and all those kinds. And you get it usually when you're outside doing exercise, which may also relate it. So However, it's not really a confounder. I just need some characteristic in here that will help us to catch enough people to be able to build our cohorts properly. Meanwhile, we have all of our components that we are excluding from our study. And this allows us to then create a group of otherwise relatively healthy people in here who don't have any strokes, vascular dementia, Parkinson's disease. I'll go over more of why exactly these particular things were chosen later. And so you can think about how you want to choose your particular cohort definition components. But what I want to show you, of course, is how to use groups to combine things. So in this case, I created group one just by clicking this create a group button. And I added my terms to it. You can check these little boxes to add your terms to the cohort. In this case, this is my Alzheimer's having the group that, is on statins that I'm comparing for. And you can see they all have the same exclusion criteria as the other group. They also, rather than have them be included because they're on vitamin D or ibuprofen, they just have a visit. They came in for any reason, for any kind of visit to their hospital system, and then they got a statin within 1 year before that visit. So 1 year prior to showing up, they did that. So let me show you, when you create these groups, you can set up these group rules right here. And we're going to go through each one again, your number of instances, unique values, related groups, and time constraints to look at how they work. But basically, this allows you, when you create groups, to set relationships that are meaningful for them. Again, relationships in time that make sure that these statins showed up for at least 1 year in a person's record before the visit that starts them off. And I'll show you how to set that up in just a second. But these groups, being able to use these groups to define specific relationships is really important. And you can just simply click this and or function to either make sure that your second group of related terms, not people necessarily, but definitional terms of your cohort that you're adding in, must be included along with this group of people. So that means, that they must be drawn from the pool of people that is positively defined here, or that's defined here. It's going to go through, and in group two, going to look for people within that pool of people who then further meet your definitions. So, for example, if we wanted to add in people who were deceased for some reason, we could look at all of these folks, look at all of the people in this pool of group one, and then it would find within those the people who had already died before starting our study. So we could do something along those lines to make use of that information. And similarly, you can use this to create other kinds of logic that we're going to discuss right now. I just also want to note that please bear in mind that if you create your cohorts and all of this stuff is outside of a group, it means that it could occur at any point in time in relationship to the person's health record. It could have been when they were 20 years old, could have been when they were 40 years old. And that can really wreak havoc on your cause-effect relationship that you're trying to assess in your study. So if you want to look at a time when a person had an A1C over 7, in my case, if they ever had an A1C over 7, get booted out of our study, because it means that there's a bunch of other potential confounders going on in there that we just want to get out of place. If they ever had a history of nicotine dependence, getting booted out of the study, right? Cannot have this. If they ever had, what's another good one? If they ever had epilepsy, because it's related in some ways to Alzheimer's, kick them out of the study. Doesn't matter when it happens in relationship to time. These folks have pre-existing conditions that would render unclear the relationship between statins and Alzheimer's that we're really trying to carefully pick out here. So that can happen at any time, but in this, if we add time relationships within our groups, it really helps to clarify how and when these things occur in relationship to our events of interest. So please bear in mind, anything you don't group goes across, categorically across the person's lifespan. As I pointed out a moment ago, the logic, using and or logic with the groups in the same way that you use it with individual terms. can help to focus in on specific groups of people or broaden your net of people to include people who had anxiety and depression and an SSRI, for example, for either one within a year. Or, if you have different time frames within groups, you can set up people who had more than 6 months or people who had it for 7 to 12 months or something like that. There's all sorts of ways you can combine the logic here to really get very, very specific groups of people defined in your cohort. So returning back to the group rules functions that we talked about a moment ago, you can use these group rules to describe how different subgroups and groups within your study interact. We'll go through them in order just to give you a sense of it. This is as I said earlier, the number of instances function. This says how many times did a person, for example, if I move lovastatin over here, this person must have had their statin for at least 5 prescriptions before they get entered into our study, or 10, or whatever arbitrary number of, or non-arbitrary number of components you'd like in there. Similarly, you can add the number of unique instances in here, as I mentioned a moment ago. This is where if you wanted to see how many people had multiple statins or switched between statins, you could say that people have to have at least 2 or more of these statins in order to enter into your study during that time. So any of these things would be true. They do not have any of these features. They came in for a visit and they had 2 of these 3 in their record. That would be how you could set that up. I want to take a moment to explore time constraints a little bit, because this is one of the most useful features and one of the ones that I think causes in some ways the most confusion. Just move this back here. That frequently I talk to folks and they need to set very specific relationships in time between 2 events. So for example, the diagnosis of melanoma and either removal or chemo or metastasis, a definite identification of a secondary cancer. Any of those kinds of things might be things that you could include here. So by using this, where it says edit related group function, I want you really to pay attention to that because it's very useful. You can use this interface to relate these items here, for in this case, this medication, to anything defined in this set of events up here very easily. So you can see that this is the day, the index event for group 1A, which is up here, defined as either all of these things being true in their record or none of these things over here being true in their record and all of these things being true. So in this case, you can set into the past specifications for the relationship of this group, or you can set it into the future. So anytime prior to 6 months after that event occurred. Or, in this case, I wanted to make sure to specify that those folks had to have been on a statin for at least 1 year prior to entering my study. So any instance of a visit is preceded by 1 year of their first instance of the medication. And the reason this is so useful is you have all sorts of occasions in your studies, I know from people working on them over time, about relationships of diagnosis and medication prescription, or how long between one fracture and surgery for that fracture, days, weeks, months. And this allows you to really precisely set up those order effects in here. And just to show you, this would, for example, represent, if you drag these little buttons like this, so starting from the same day that your index event for group 1A starts, in this case, my visit, we would be looking ahead 1 year into the future. And that is useful. And you can also set these again if you wanted to specify injuries within 3 months and 6 months. You could set it prior to the index event. You could set this like so, and that will help you to really make sure that there's a clear temporal relationship between them. I know that this can be a little tricky, having worked with a lot of folks on it. Some people find it very intuitive. Some people need a little help. So if you have any questions about how this works, please go ahead and put them in the chat, and I will take you through them. But that temporal relationship function is really, really, really important for all sorts of processes. And you can chain these together to get all sorts of complex relationships between your groups. Additionally, in this case, I have added the time constraint where it says add time constraint in the little group rules box typically. And I wanted this group to occur after January 1st, 2015. Partially just to limit the size of my cohorts because I'm grabbing random people, but also, the average length or the potential length of most of these electronic health records is somewhere on the order of 20 years. And a lot has changed in terms of standards of care and assessment and technology and clinical expertise, and all sorts of stuff has changed so much that if you're comparing people today to people in the year 2005, well, you're looking at a very different medical system back then with very different kinds of people, very different outcomes. That was also generationally different people with, who lived through the Great Depression and had other health issues, chronic health issues that they were dealing with. Now we have a different groups of cohorts of people coming through the health system. So for me, it's very important that we don't look too far into the past or we start comparing apples to oranges. As they say, the past is a different country, and we want to make sure that we're comparing people accurately. So you can set dates either relatively to each other. You can say, I want to see from today, whatever today is, 6/23/2025, when this was recorded, or when I was teaching this. We want to look 1 year from today backwards, and that date will auto-update every time you run this query and update it in the future. It'll change that date for you. Or you can enter specific dates. In this case, I arbitrarily chose January 1st, 2015 to today. So we have a good chunk of years in there to collect data, and that allows us to capture a lot of people in there. So those are some things to keep in mind in terms of your time constraints. I find those really valuable, and we use them all the time in different kinds of studies. Please go ahead and ask any questions, though. Oh yeah, one thing I wanted to point out, I strongly recommend naming your groups 1A and 1B because it gets really hard to remember that after a while. But if you name them, it'll helpfully rename insert the Mad Lib style into this little sentence summarizing your time relationship. So in this case, the relationship between 1A and 1B is the first instance of the first statin 1 year before, which is the name of 1B, occurred at least 1 year before any instance of the placebo index event. That is the visit that defines the start of the study. So by naming these, that was a little confusing, but if you name these properly, surgery, medication, or diagnosis, treatment, or something like that, it'll help you really understand and articulate in English, plain English, what exactly is happening to the relationship between your two cohorts. And I also want to highlight that you can change positional relationships in here. So any instance of you can have it be any visit or any instance of a visit or the most recent visit. If you were looking at, for example, the most recent A1C value in the person's record, you could define it this way. Or you could look at the first instance, the first time they were diagnosed with a melanoma, or the first time that something occurred. So these can really help you with that time definition in the related groups. And again, this is kind of how mine is set up. We have 1A can contain all of the exclusion criteria. In here, you can just stack them all up so that in this case, you have your people getting ibuprofen. In an old version, I was using ibuprofen and aspirin, and they never during that time frame had any of these features. Later on, I chose to just categorically exclude these features: Parkinson's, cardiac arrest, vascular dementia, any of those different confounders. I just booted them all out. But you can determine how you want to do that, whether in relationship to your starting event, your index events, or in relationship to some other component, or categorically. Here 1B again includes our statins and that temporal relationship with the first instance. Back then I was using at least 5 years ago to make sure that they've been on statins for at least 5 years. And as I said, say it out loud. This really helps to make sure that your logic and your relationship is orderly and correctly composed. So related groups, as I said, is a very powerful function, and you can use this to create stepwise approaches to creating related groups. So you can only create one, 1A and 1B per group. So you can only create one set of temporal relationships between two events per group. But as you add more groups in here, and we have group 2, and you start creating additional related groups, remember, these aren't groups of people, these are groups of terms that are being added together, to define the people in your cohort. So I'm just going to add these terms in here. And you can see that even though you actually need a positive, we could say we actually want to include, we want to have people who had strokes be a defining component, but didn't have vascular dementia or the zoster virus at any time. And then you can define additional relationships between them. So you can also, for example, duplicate your groups and change time relationships between your visits. So this would be anybody who had been on a statin for at least 1 year prior to the visit. And we could go back up here. We're going to add another visit of some type, any of the types of visits that are available. And I am going to make it so that that visit, which is ideally going to be the same as this visit, has a time relationship with another feature we're looking at. So in this case, somebody shows up for a visit and has a stroke, or has had a stroke or has been diagnosed with a stroke, or an infarction. So that can be a great way to really chain together multiple kinds of logic to make sure you're getting exactly the right people that you're looking for in your study. And they call this in TriNetX the stepwise approach to defining your groups so that they have different, similar features that enclose the correct group of people in your Venn diagram. One thing that's handy, just FYI, is you can copy your group. Let's say you spent all this time developing one of your cohort groups. You can simply hit the copy button, and I'm actually going to blow up this group here. One second, throw these back, and you can delete these cohorts pretty easily, and you can also paste them. So when you paste it, it just makes a copy, and then you can change and say, let's say you wanted to include people who'd had a statin for anywhere up to 6 months after their visit. You could easily do that as well. I'm not sure why you would, but you could. Please let me know if you've got any questions in the chat. We can take a look at it. I'm going to delete this group. But yeah, group functions, really valuable. And you can also, as I said earlier, change the logic of your groups to include and or. That means that it'll look through and go top to bottom and look through your groups and say, are we looking for people who meet both of these characteristics or one or the other? And that is really valuable when it comes time to defining who's in your study. It could be people with 2 different types of surgery. Maybe one surgery is closer in time, so you need to create 2 groups with 2 different time definitions within them. That can be really useful as a feature for making sure you're getting the right people. So remember, as we exit this section, groups are groups of terms that can be combined to define a cohort. They are not groups of people that you can compare. If you create a cohort with a bunch of different groups, and then you try to load them into your analysis later, you'll find that you won't be able to. That when you create a group that comes out as a card like this. These are the kinds of, these are the kinds of cohorts that you can then go and compare in the next phase when we move into analysis. You can compare these groups against each other. So I can compare XP20, this is my experimental group version number 28 with from the last 10 years. I can compare them against my control group, number 28 from the last 10 years. And however, you cannot control anything. If I put all of my comparison groups into one cohort, I'd be unable to compare them because they would actually not be two separate cohorts of people. They would just be two groups of terms, and you'd be defining them possibly all people, let's say, with statins and all people without statins in one group. And that would be kind of a useless endeavor to do. You want to make sure that you're creating them in different groups. And we'll see the impact of that next week, why you have to do it that way a little more. So groups are groups of terms that can be combined to identify people. Cohorts are groups of people defined by those groups of terms. So just being aware that these are your cohorts over here. These are your groups of terms over here. It's a little bit confusing. I'm not sure why they chose that nomenclature, but it is something I know that is a little bit of a sticking point for people when they're trying to figure out exactly what they're analyzing later on. And finally, as a point, a query is a search process that produces these little query cards that are your cohorts. So if you got any questions about that, please raise your hand, unmute yourself, or otherwise, let me know in the chat and we can talk about that. As I said, a common mistake is putting all of your cohorts into one group of terms, or one cohort essentially. You can compare across these groups, but you can't compare across these groups since they're defining one cohort. Okay, so that's the main process of building cohorts using all the various cohort features that are in there. I also want to point out to you a function called the explore cohort component. It's right under here. You have your query builder up here and your cohort explore cohort function down here. So I'm going to run this, and actually, you know what? I think I already have one run. Yeah, here we go. Okay, this is the version where Julia Child takes her already made cake out of the oven. So this is our cohort, our control cohort, which is people who never were exposed to statins, never had a statin in their record anywhere. When you hit the explore cohort function and you hit the run button, it will give you a window into all of the people in your cohort. So it'll give you your demographics. This is, the average age in years and the distribution of ages in years for each year of your cohort going on forward. In this case, our cohort starts at 45 because we wanted to catch some folks with early onset dementia that these days is getting caught as early as 45 and in their 50s. And then you can see how these groups kind of trail off as people expire or move out of the cohort. It'll give you kind of the basic demographic information, male and female, as well as ethnicity and race. I just want to point out really quickly that for reasons related to the federal government and how it defines race and ethnicity, ethnicity really just means Latino or not Latino. And in this case, I really think that only the kind of positive version of that, Latino, is a particularly useful category. If you see, and you will encounter this, I'll talk about this under propensity score matching, your not Hispanic or Latino category and your unknown ethnicity category really mean nothing in this context. We don't know what they mean. They could mean that the person's multiracial and they don't like to be included that way. It could mean that the health system does not include Latino as an option, so people have chosen other things, and there's no information on their ethnicity. So we can only positively identify people based on their Latino background if they check this box. Same with male and female. We don't know what unknown means. It may or may not mean transgender or any other kind of non-binary category, but we can't say that for sure. So I really caution people against using the unknown variable for anything. And similarly with unknown race or other race, we really don't know what those mean. But you can see we have our white, Black and African American, Asian, and Hawaiian group in here as well, and indigenous. If you want more detailed information than this, though, you will probably have to use linguistic information, because that's the only kind of information that's pretty universally collected for people, depending on their ethnic group as well. In a lot of cases, because those are folks who need that language to be recorded for translation purposes. So if you wanted to identify, for example, people who speak Igbo who are Nigerian or West African, and whose English, though English is pretty well established as a common language in Nigeria, you may find that that's a way to identify people in your pool who are from that kind of sub-background within the racial categorization. Again, because these categories are, I would refer you to the book Fatal Invention, which has an excellent breakdown of why these categories make no sense and really have no medical bearing. However, they do tell you a lot about inequalities and inequities that we would see in the US healthcare system. So there's a whole lot more to be said about being very careful about how we use these characteristics to look at social determinants of health and differences in outcomes. But for right now, we'll just leave it to say that that's something that you need to be very aware of whenever you're looking at, for example, comparing outcomes for Latino patients versus outcomes for white patients, and the very, very deep limitations of those concepts and terminologies across all research that we do. So that's your demographics. Let me just see really quickly. There's a first year who did a really, really great job of coming up with a great mnemonic for this. He called this "Doctors Don't Pay Money Late." That's your demographics, diagnoses, procedures, medications, and labs. And those are the features that are available to you in pretty much all of your Explore cohort functions. So if you're doing you can see your demographics we just looked at. Now we're looking at diagnoses. This is every diagnosis that has been both either included in our study or generally is part of any of these people's records. So we can see about 41% of the people in our study have some kind of metabolic disorder going on. In this case, hyperlipidemia, which is why they are either on statins or not. We have about 10% of our no statins group walking around with hyperlipidemia or hypercholesteremia or any of those features. And you can dig in here and you can look at these diagnoses within 3 months, 6 months, 12 months, or 24 months of the key index event that we set in our study, and the first day that study was true, or those characteristics were true. You can also sort them by chronic and acute, depending on what your interest is in the study. There's actually, let me see if I also screenshot that. You can see, yeah, as we pointed out earlier, here's your demographics and your diagnostic components. One thing I do want to point out to you that's very useful is as you're building your cohorts, you might find unexpectedly that there is a lot of diseases of the digestive system occurring in your group, other diseases of the intestines that you wouldn't have thought of, right? That maybe even in your clinical experience, you haven't seen a lot of features like this. You can, for example, constipation, I guess kind of makes sense. By clicking on the item here, you can add this to your cohort directly. You can say add to must have or add to cannot have, and that'll allow you to really easily jump back and see it, in your cohort here. So you don't have to go and memorize that ICD-10 code and go add it to your cohort finder. It just can get added straight away from this view. And this is the same with any of these procedures that you might use. You can see over here for surgeries. Over here, we're using the CPT code, but you can also use ICD-10, which is another international use structure for medical procedures as well. This is the ICD-10 PCS category. I just want to call attention, again, to note that as you're building your queries, you may want to look in both, because different hospital systems use CPT and other hospital systems use ICD-10. And you want to make sure you're not missing patients because you're only looking at one set of procedures or the other. Fortunately, a really quick Google search will often turn up all of the things that you're looking for that. And here, for example, if you wanted to see everybody who'd had a diagnostic image or radiologic examination of their chest, then you can see all of these different things. So we've got X-rays and stuff like that. It can be really easily done, but there's all sorts of pretty much every kind of procedure that's billed for exists in one of these two structures, and so you can catch the people that you're looking for in here. You can also look at your medications and see what are all the different kinds of medications in here. There's some additional options. You can just, look across all medications if you want. You can use different kind of taxonomic systems, whether it's the VA or the ATC system, to find things. You see that a lot of the people in this cohort are on some kind of therapy. We can see they've got other heart stuff. I guess ibuprofen in this case is one that they're including. It's a weird place to put it, but whatever. And so you can see that these are some of the ways that they divide out medications. Finally, we can look at labs. Labs are a complete mess because the LOINC system doesn't really have a curator the way that you'll find with ICD-10 and CPT codes for procedures, and for the ICD-10 codes for diagnoses, and even for medications. There's a very logical structure for how these things are set up. And once you understand it, it's kind of like the Dewey Decimal System. It helps you navigate all of these different terms that you may have difficulty searching for. LOINC doesn't really have that. So to help us out a little bit, for basic stuff that's very common, TriNetX has curated together multiple codes from the LOINC system to allow you to look at, for example, the sodium volumes in people across multiple kinds of tests. And you can see there's about 48 million people have had this test at one point. It's a very common one, right? Obviously in their in the health record. And you can generally see the distribution of those across the relative values in here. So TriNetX brings together multiple codes, in this case, all of these ones in blood, serum, or plasma, or I guess it's this is an additional kind of version of the lab. But yeah, you can do a lot of really great work of seeing what the distributions are and what kinds of values might be important to include in your study. And again, these are all the TriNetX curated ones. But if you want to look at them categorically, you can do that to help you see the different types. Here's blood type and stuff like that. That you can include. And you can also look at them by, if you Google the test that you're looking for, you can search for these by the number, the LOINC number. It's these multi-digit components, and that'll tell you there's the GFR kind of one there. You can look at BMI, body weight, all of these different values that have LOINC analogs or have been brought together by TriNetX. So your doctors' demographics, don't, diagnoses, pay, procedures, money, medications, and late, labs. Doctors don't pay money late. Be sure to check these. You can also, if you are interested in looking at genomics and oncology, you can look at those tabs as well. But that is, we'll leave that for a future version. I got a question. Does the lab value indicate separate, entirely patients? Does it include every iteration of the lab ever done? So wondering if there could be confounding data. You can, when you choose how to select people in the study, you can specify whether you want the most recent lab result relative to the index event, or whether you want them ever to have had that. So if you want to know if the person has, for example, you can also set it up so that you would want to see anybody who ever had a body weight of 250 and then within 6 months had it decline to 200. You could set up the labs to do that for you pretty easily. So it depends on whether it's going to be a confounder or how it might be a confounder. It's possible, but generally this is a pretty easy way to identify people based on their lab values. And yeah, please go ahead if you have any other questions in the chat. I'm just going to do a quick review. One thing I would say is I also do not recommend when you're looking at, for example, either the CPT codes or the diagnostic codes, I do not recommend using these top-level codes as inclusion or exclusion criteria or propensity score matching, and we'll talk more about that in a couple weeks, features, because diseases of the genitourinary system include so many things, right? All sorts of different features in here, from kidney failure to all sorts of issues in UTIs. Everything can be, it can just be a whole mess. So I don't recommend using the top level. I recommend going, several layers down to focus on exactly what you're interested in, rather than diseases of the digestive system, which can include cirrhosis of the liver, right? That might not be what you're really interested in. You might look at, if you wanted to know about whether a person's having difficulty with digestion or something like that, you might want to look more specifically at their diseases of the salivary glands, I guess. But you don't want these two things conflated. And in TriNetX, if you pick a top level code, it will pick everything below that as well, which I described last time, but really makes a difference here. If you add in diseases of the digestive system, it will include anybody with any of these features in here. Everything from hemorrhoids to irritable bowel syndrome, just in this subsection of that. So that's something I want you to be aware of, selecting top-level codes at your peril. One thing you can do that's very useful, should you want to do a deeper analysis of some of these things, you can use this button here to export this whole table, all of the table and its sub-table components as well, including as far down as the hierarchy goes for each group, to an Excel spreadsheet. And that can be really useful if you're trying to organize things, or otherwise take a look at what features are common to your cohorts that might be confounders or not confounders. And you can see that when you click on that little button, it'll give you a little data export function here that you can use to figure out what you want. And you can see it looks something like this, with it where it tells you the code system, the code series, here's R06, 00, 09, and so forth, and what number of people and percentage of the cohort overall is being included, and some additional information. So this can be very valuable if you are trying to figure out and look for potential confounders that you might not necessarily immediately have thought of. And you can use Excel to, and all the functions of Excel, to filter and sort these very nicely. Finally, in reviewing procedures, CPT codes or billing codes that are structured around those specific procedures. Again, the reason that ICD-10 codes exist is that the AMA maintains CPT codes, and they're very expensive. You have to license the whole system from them and get updates and stuff like that all the time. So ICD-10 PCS codes are much more used globally. They are used in other health systems that, for one reason or another, don't want to use CPT codes or CPT AMA branded components for medical billing and for procedural analysis. So as I said earlier, try to include both CPT and ICD-10 codes when you're doing that. Again, medications are grouped by types and use, and they can sometimes be broken out to make it a little easier to find things. Labs, as I said, you might want to switch. Let me revisit this really quickly. In your labs function, you may find that you can't find the exact lab you're looking for. And it's because a lot of times this defaults to common labs, when what you really want is all labs categorically. So rarer labs, things that are not as commonly used, you would need to find them under the all categorical or all numeric labs, as opposed to just the common labs. And again, lab profiles can provide you with really important and useful information about distributions, in that case of triglycerides. Another window with some very useful information. That kind of concludes our discussion of the Explore Cohort function. Your doctors don't pay money late. But for those who are interested, just quickly look at the summary stats window. So basically, to get there, you would go under your window, under your left-hand menu to Summary Statistics, and click the Run button, just like I'm doing right now. And you wait a little bit, And what you'll see is one thing that people ask a lot for that TriNetX just does not do for a variety of reasons, is geographic distribution by census region. This is the best we can do in terms of geography in order to keep patients safe during this as well. And so you can see the distribution, the raw distribution of the patients into those 4 regions, Northeast, South, and Midwest and West. So that can be useful if you are looking to see if there are differences between regions and whether there are differences in outcomes by region or certainly whether there are more people from your cohort in one region than another. And you can click on these to get those, to get an interactive version of it. But this is as detailed as it gets by geography. And I just like to point that out, which you'll see. Sorry, finishes loading in just a moment. All right, we're kind of coming towards the later part of our study here. We've looked at a lot of interface features. Are there any questions so far? Anything we want to go on? I know there's a couple of confusing things in there that can get in the way of a smooth launch in TriNetX. For example, how groups and cohorts are related. Any questions about that or anything I can clarify on that? Yeah, well, while we wait for that to show up, I'm going to move on to building your counter cohort. I'm going to talk about this really quick. So what's a counter cohort? Well, if you're comparing outcomes for a group, let's say you're thinking of it in experimental and control or presence absence, you can use your experimental group to kind of quickly create your second cohort. So for simple comparisons, you don't really have to start again all the way at the beginning, the way that you did the first time to add in all your features. For more complex comparisons, you may have to adjust your timelines and your term filters and things like that. But basically, as I said earlier, it's very, very easy to, I'm going to just cancel this to get back to our core features. It's very, very easy to copy your group terms using the copy button that you're going to see here. And to create a new query and either import the old query, actually, that's maybe even an easier way to do things. You can import your last version. And you can edit it and paste additional logic in here as well. Sorry, also to show that you can basically really quickly duplicate these using these functions. And you can always use the delete key. It looks like a exploding group. You can clone your query and delete components out of it. And it makes it really easy to develop your structure without having to, or you can to regroup your components without having to go through and add all of your features again. But you want to really think about it first. Ideally, think about what will be easier to build first. You want to build your control cohort, and then after that, build your experimental cohort, or consider which one's going to be easier to convert into your counter cohort. So in the stat study, as you can see, I have in my control cohort a lot of different kind of ungrouped features. And in my statin cohort, it was a lot easier to basically start with that and add in my features. So I really just cloned my control group and added some additional time relationships in there to really make it work well. So a methodological note, though, that I want to make about that is when you're asking about a counter cohort, I always want you to think about what are you comparing between these two groups. A lot of projects start with a cohort and compare them to a big population. All pregnant women with a particular condition versus all pregnant women without that condition. That was one with Huntington's disease. And the problem is all pregnant women are not really a very good comparison group for all women with Huntington's disease. There's lots of stuff going on in that very small pool of 200 or 300 women with Huntington's disease who are pregnant, or people with Huntington's disease who are pregnant, that really don't make them a good comparison group for all women generally. There's lots of other stuff going on in the all women's category with so much variance in that doing that comparison doesn't really make any sense. So it seems natural to do it that way, but the amount of heavy lifting that you're going to have to do when you do your propensity score matching is going to make it come out really poorly. So I don't recommend doing it that way when you have all of this versus none of this. It really creates problems of scale. So especially when you're working with big data, that can really introduce bias and all sorts of randomness that will actually make your study harder to conduct. And one thing I often remind people about is please make sure that you're not just trying to chase large numbers of people when you're developing your cohorts. More is not always better. You want to make sure you have the right people that you're comparing. And when you do that, you have to really think about who is it in my case control or in my cohort study, who am I really comparing, who am I looking at, and how do they form or don't form a particular or a good contrast for the outcome that I'm looking at and the question that I'm asking. So just returning to our worked example, I used Perplexity to quickly, I want to discuss really quickly the role of AI in helping you to define your cohorts. While it's essential to do an up-to-date literature review, some areas that you might be working in are so large with so much research coming out all the time, it can be very difficult to manually conduct a literature review of potentially thousands of studies and to evaluate their quality and all those kinds of things. So I recommend using Perplexity. I like Perplexity for these purposes because it actually cites its sources and tells you where it's from. Some people use open evidence and there are different technologies. I just happen to like Perplexity because it's broadly, its most useful features are pretty free. And you can use this to help you quickly identify components for adding into your comorbidities for your study or exclusion criteria that you might want to include or exclude in your study. This is not a replacement for years of expertise in clinical research, but it is a way for you as you're developing your own expertise in an area, if you're a medical student or as you're getting familiar with the latest research in the field, this is a great way to help you really summarize that stuff and get up to date as quickly as possible. That way, when you go to talk with another expert or an expert that you are working with, an attending who's very senior, has worked with a lot of patients with these conditions that you're working with, you can have the best chance of presenting something that's number one, high quality, and number two, gets you out of the initial phase of defining your cohorts and to something that people can critique. It's a lot easier to critique something that's partially formed than to critique something that hasn't really been done yet. So using AI, and specifically I like Perplexity, to identify those comorbidities and potential confounding features or definitional features of your cohort can be really, really useful. Based on that, it turns out that there's a whole range. I think there are 16 different exclusion criteria that we brought into this study to make sure that we weren't introducing complexity into our Alzheimer's and statins study. This isn't comprehensive, but it does cover a whole range of existing theories. Why did we do it this way? Well, when there are contemporary and competing metabolic hypotheses about the development of Alzheimer's, neurological hypotheses, cardiovascular hypotheses, and viral hypotheses, and they all have very strong evidence indicating that it's probably several of these things at the same time colliding. It could be constant inflammation. I know that our own Dr. Carson looks at the role of glial cells in helping to resolve injury and insult to the brain and to the nervous system. And so a lot of these different components kind of address that, including things like prion diseases, right? To what degree is in every country where you see beef increasing in consumption, you see increases in Alzheimer's rates. Could be nothing, right? Could just be a simple correlation, or part of it could be prion diseases that we know a lot of different animals carry. Mad cow being the most famous one. So I just wanted to exclude that as a potential source of variance. We don't know how much cow our patients in our in our groups are eating, but we do know that they have not been diagnosed with mad cow disease in their record. Interestingly, cancer was one that I didn't know this because I, once again, am not that kind of expert, except as I was learning. But histories of cancer are actually associated with an 11% reduction in Alzheimer's disease diagnoses. Cancer patients have slower cognitive decline, and it doesn't seem to be related to chemo, radiation, or cancer drugs. I'm not an expert, and I would be fascinated to hear more about this. But there, as far as I know, is no relationship. So I did not exclude people who have had cancer in there because it doesn't really impact. Now, it can impact all sorts of metabolic issues, but for our purposes, it does not seem to increase the odds of Alzheimer's disease. So we did not exclude those groups. Though for many other kinds of studies you would be doing, you might want to do that. Again, you can use the query builder, as I pointed out earlier, to look for confounders or common features to your cohorts that might be a potential confounder, and you can exclude those and add them to the cannot have function. Great. As we're closing up today, I want to draw your attention to one last feature of this phase, your cohort diagram. And this is a very common feature of TriNetX publications that I think is really great. I actually think it's a really nice economical way. I think all studies should have some version of this, especially if you've got multi-pronged or multi-armed trials and things like that get very complicated. These cohort diagrams provide a really clear, succinct map of relevant inclusion, exclusion, and cohort criteria. And yours doesn't have to look exactly like this. I just liked this from a particular article on COVID-19 outcomes. But basically, my rule of thumb for this is this should be accurate enough and comprehensive enough that I should be able to hand this over to one of our medical students or one of our attendings, and they should be able to reconstruct your study based on your cohort diagram, just the way that you would with a Prisma diagram or strobe checklist or any of those kinds of things. You could use this as a way to really do a good job on it. And you can see here, so these are so far the worked example that we've been discussing. Here are my characteristics that are defining this. I did this back in July 2024 last year when there were about 150 million people on TriNetX. The only people included in ours were over the age of 45, which is about 59 million people. And you can see that we excluded everybody who met these characteristics, leaving about 4 million people in that total pool. Total meeting criteria for this. These are our groups that meet our inclusion or exclusion criteria, and our analysis time frame that we look at. And later on, we changed it to 1 year to any time after. Always make sure to double check your math and make sure you've got all your numbers correct in your version. And the reason this is so important, let me return to that, is TriNetX is a very dynamic network. As I mentioned earlier, there are large fluctuations in who's on TriNetX in terms of what networks are available. And you want to make sure that somebody in the future, 5-7 years from now, who's referring back to your study, can tell how many people were, what the network looked like when you were there. There's no way to freeze it and no way to look at things in the past. So documenting it is a really useful way to help people assess how relevant your current analysis is to their future version of the network, whatever it may be. This actually even is important because we are looking at studies sometimes of COVID for their structure, studies from 2021, and there's now 100 million more people on this network than there were back then. And that might impact how well we view those findings now, how relevant they are, whether we want to update them before we move on with using their structure or something like that. And please, I recommend always using the numbers from the day that you run your last version of your analysis for your write-up. That really helps out a little bit for it. And for those who are interested, when you're doing things like posters, you can use one of our cohort diagrams, which I will put in the chat, to develop your cohort. In fact, if you click on it, it'll make a copy of our cohort diagram template to your Google Drive, and you can edit it and go in here. You can see I structured it exactly like the one I just showed you in a minute ago. It looks just like this. and you can, edit it, add it, move it around, whatever makes your life easy to get this done. I tried to be as clear as possible about what kinds of information you should put in here. But if you're one of our students, please do come see me and I can help you work this through. And you may find yourself doing multi-chambered versions of these analyses where you're looking at different related phenomena. I'm providing diagrams for as many as 3 studies at a time. So you are free to make a copy of it. You can save this to a ping file. There's instructions for that over here. And then you can put that on your poster and develop all sorts of really great, include in your manuscript or your posters and use that to really help guide people in the future as to what you did. So that's it for today. Thank you for the time. There's a couple questions. I'll just stop the recording in a second and address those. But next week, we're going to talk about comparing cohorts and propensity score matching. This is the stuff that I think people really want to know about, right? Obviously, that's much more fun and interesting. But in order to get to doing an analysis in TriNetX that makes sense and using all of the wonderful analytics tools that are available in here to kind of figure out what your study's findings are, right? To finally answer your question. Well, you need to really have strongly defined cohorts that are internally consistent and methodologically sound. And when you do that, you'll have a much better shot at developing a really good answer to your question. So we're going to talk about that next week, as well as propensity score matching, which is a really cool approach to balancing bias in retrospective cohorts and retrospective cohort studies. So with that, I'm going to stop our recording for today. And